Thank you, and thank you for joining us for the COVID-19 Daily Media Call for May 11th. Governor Walz is not on today's call. Our agenda for today will start with the latest situation report on the COVID-19 outbreak from Minnesota Commissioner of Health, Jan Malcolm. Following that, we'll hear activity updates from MDH Medical Director and State Epidemiologist, Dr. Ruth LYNFIELD, and MDH Infectious Disease Division Director, Chris EHRESMANN. After those updates, we'll open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. Globally, as of early this morning, we were at nearly 4.1 million cases of COVID-19 disease and 283,000 deaths. In the United States, as of this morning, we were just at 1.33 million cases and 79,500 deaths. Here in Minnesota, as of yesterday, we have a new total of 11,799 cases. Over the weekend, we saw an additional 479 cases announced on Saturday. That would have been Friday's totals, and an additional 532 cases announced on Sunday, which would have been Saturday's totals. And in addition to these case counts, we can share with you that the overall case median age, the point at which an equal number of cases are older and younger, total confirmed laboratory cases, 44.1 years old, evenly split between male and female. In terms of the doubling time that we've talked about, we are still at 9 days, actually increased by 1 day. We were at 8 days of doubling time in the total case count most of last week, and as of today, that figure is at 9 days for the doubling rate in total confirmed cases. Fully 1/3 of our confirmed cases are in Hennepin County, 40% between Hennepin and Ramsey together. And Hennepin and Ramsey accounted for about half of yesterday's new cases reported. We also have a new total of 591 deaths in our state. This reflects an increase of 20 additional fatalities that were reported on Saturday and 13 that were reported, 13 reported today and 20 reported on yesterday. 9 of today's 13 additional deaths were occurring in residents of long-term care facilities. 9 of the fatalities were in Hennepin County, 2 in Ramsey, 1 each in Rice and Stearns. This total includes 6 people in their 90s, 2 in their 80s, 1 in their 70s, 3 in their 30s, and 1 in their 50s. As of today, there are 452 patients in the hospital, 194 of those in intensive care. And we will continue to report the race ethnicity breakdown on our website between the number of cases, hospitalizations, and deaths, as we are tracking with concern the fact that, particularly among the Black population, the rate of case detection and hospitalizations is significantly higher than the proportion of the population. I would like to just mention that the model, the third version of the updated model will be coming out this week, definitely. And I know I've been saying that it was coming soon for several days now. We do have Stefan Gildemeister on the call as a resource if you have questions about what is going into the new model. It does incorporate a number of new factors and updated data. We've been, as I understand it, and Stefan can comment further on it during questions, it is currently the data are being calibrated and final vetting is going on with our University of Minnesota partners. So we will be getting this out this week. Certainly the governor expects and will see an updated run of the model, which hopefully will be completed as soon as this calibration process is complete. In terms of the volume of tests, we had almost 4,700 tests processed by all the labs who reported on Sunday, yesterday. And that's good news that we're consistently processing over 4,500 tests statewide, even over the weekend. and we anticipate that number continuing to grow as we get into this week. We do want to just once again restate our guidance that people who are experiencing any symptoms of COVID-19 can and should be getting tested. We have that capacity now that had not been in place weeks ago, and we want to make sure that folks are aware that they can and should be tested if they have symptoms. Further word on the outbreak in now 7 counties with food processing plants. So those 7 counties with food processing plants account for about a third of the new cases that were reported yesterday. So that proportion of new cases seems to be stabilizing among the food processing plants. And KRISTEN can probably comment further on that if you have questions. Before turning it to Chris, I would like to welcome Dr. Ruth LYNFIELD to the call and ask Ruth to comment a little bit on a piece of good news that we received over the weekend, and Ruth and team worked very quickly to get the medication called remdesivir out to the hospitals which currently have COVID-19 patients as inpatients. So I'll turn it over to you, Ruth, to explain what remdesivir is and how it will be used.
Thank you very much, Commissioner Malcolm. So remdesivir is an antiviral medication, and the FDA issued an emergency use authorization of remdesivir for treating COVID-19 on May 1st. This drug offers a treatment option for people with severe COVID-19 infections, and preliminary data found that it reduces the time it takes for patients to recover. According to the National Institutes of Health, a large study recently showed people receiving the drug were able to be discharged from the hospital within 11 days on average, compared to 15 days in the placebo group. Minnesota received a small initial shipment of remdesivir this weekend from the federal government. It came in on Saturday, and we distributed it Saturday night and Sunday morning. We allocated it to healthcare facilities for the treatment of people hospitalized with severe COVID-19 cases. We worked with infectious disease physicians, critical care physicians, and our ethics group, the Minnesota COVID-19 Ethics Collaborative, to come up with the guidance. The guidance is posted on our website along with an information sheet about this, and we have also posted a link to the emergency use authorization from FDA. We are expecting actually to get an additional small allotment tomorrow, and we are making this allocation with an eye for maximizing the number of lives saved, taking into account both risk and expectation of benefit. Thank you. And now I will turn it over to my colleague, Infectious Disease Director, KRISTEN.
Thank you, Ruth. I'd like to talk about a couple of different things today. The first is case investigations. There's been a heightened interest in many of the aspects of our public health work that typically people don't care about on a daily basis, but certainly now with the COVID pandemic, we're getting many questions. And so one of the areas I'd like to focus on today is talking about case investigations and the subsequent contact tracing. Case investigations are really a core element of a public health response to an outbreak of an infectious disease, and we use this tool with many different outbreaks, including the 2017 measles outbreak. So it's a tool that is an important one in addressing outbreaks. What we do is we interview someone who's ill and not only learn about their illness and other aspects, their symptoms, that type of thing. But we also want to get information about settings where they may have spent time, as well as individuals with whom they may have had close contact. And so this is a tool that we use to identify if there are any high risk or vulnerable populations who may have been exposed. Is the individual a healthcare worker? Certainly it's something that we've used as we've identified outbreaks in processing plants and other manufacturing facilities. So it's an important tool not only to learn about an individual's illness, but to learn more about the setting where they may have exposed others or been exposed. When we think about our response in EPI, we look at person, place, and time. And certainly with our case investigations, that helps us understand more about both the person but also the place. And during this outbreak, we've had some challenges related to our case investigation. First of all, we're learning about COVID-19 as a virus. And when we first started doing our investigations, we were looking at settings and potential exposures from the date of an individual's onset of symptoms. But as we've learned more about COVID and identified the fact that individuals may be able to spread disease prior to developing symptoms, we now are looking at the 48 hours before onset of symptoms. So that's some of the changes that we've made. Certainly, we've had challenges even as we've seen more cases in processing plants, manufacturing, and in our congregate care settings. We've had many more individuals for whom English is a second language. And so the challenges of ensuring that we have case investigators who can communicate with them in the language that will be most comfortable for them has been challenging. We have recently ramped up the number of employees that we have working on case investigations, and we're adding additional individuals to the group with the goal of having 460 case investigators onboarded by the end of this week to help with the increase in the number of cases. As we continue to learn about COVID, our approach to case investigation is evolving. Right now, we contact positive cases when they are reported to us. However, as the testing ramps up, we anticipate that there will be many, many more positive cases identified. And so we want to make sure that we're doing outreach even before an individual receives their test results. So we're now evaluating a model that would contact high-risk cases when they're being tested in addition to all the positive cases. So in other words, we would not be waiting to receive test results. So as you've heard, we are in the process of looking at how we can expand the individuals who are doing case investigation. One of the important elements of this, however, is that we really need Minnesotans to participate in these interviews. We generally get very good cooperation, but there have been cases when it's been difficult to reach people or where they haven't accepted our calls or returned our calls. And in order for the work that we're doing to be effective, we do need people to respond when we reach out to them. And then let me just mention something that's a bit different. I talked about this last week, but I really want to mention the importance of making sure that children continue to receive their well child visits, even in the disruption of COVID-19. CDC put out a morbidity mortality weekly report. This is their communication mechanism, and it highlighted the effect that COVID-19 pandemic has had on pediatric vaccine administration. Since March 13th, when our U.S. national emergency was declared, we have seen a decline in the administration of the ACIP recommended childhood vaccines and measles-containing vaccines. And so as we review these data, it's a reminder to us that even as parents are addressing COVID in the community and working with, lack of child care or all the other things that the challenges that they're facing, we want to make sure that they are keeping their children up to date with their vaccinations and getting those well child visits. Those visits are important not just because of vaccines, but because of the many other developmental milestones that are addressed. So we want to make sure that as social distancing requirements are relaxed, that children who are not protected by vaccines have the opportunity to get those vaccines so that they are not vulnerable to diseases like measles. So I just want to make sure that Minnesota parents are reminded of the importance of keeping their children on track with necessary well-child visits, even during the COVID pandemic. And then one additional piece, we've talked about dental offices. I want to acknowledge that dental offices in the state are allowed to resume elective care as of today. However, they continue to prioritize their individual patient needs based on the setting, staffing, and available personal protective equipment that they have and their individualized facility plan that was a requirement under the governor's executive order. So patients will gradually be able to seek elective care from their dental professionals, but understand that urgent needs will be given priority. And dentists need to continue to be mindful of their current personal protective equipment supply, both for themselves as well as their allied dental professionals. So we just want people to be aware of the fact that while dental offices can resume elective care today, there are a number of factors that they must consider, and so patients should be aware of that and recognize that this will be a gradual process for reopening. And with that, I'll turn it back to Mike Schomer.
Thank you, Chris. We will open it up for questions now, and as we do, we'll ask that reporters limit questions to one primary and one on-topic follow-up, and that we limit the number of questions from each outlet so we can get to as many outlets as possible. With that, operator, we are ready to take questions.
Yes, sir. And at this time, if you would like to ask a question, please press star 1 on your telephone keypad. Again, that is star 1. We'll pause for a moment to compile the Q&A roster. And your first question comes from the line of Jeremy Olson with Star Tribune.
Yes, hi. I wanted to ask a question about modeling, and I don't know if one of you could particularly answer that, but it was disclosed today, or came up today, that an additional modeling scenario was added to the last round of modeling the state did, and it looked at the impact of keeping a stay-at-home order in effect through the end of the month. I'd been hoping that someone could address the impact of why that was added, what the thinking of adding that was, and what it says about our response, whether we should continue the stay-at-home order or not.
Hi, this is Commissioner Malcolm. I will appreciate Stefan joining us as a resource for the call today. So, Stefan, would you take that one, please?
Yeah, thank you, Commissioner. Good afternoon. The scenario 5 that you're referring to, Jeremy, was just a bit of an afterthought. The governor's office at some point had asked us to model that as a part of that as another scenario. We initially had not planned on adding it because, as you know, we're in the process of updating the underlying structure of the model, so it would effectively become outdated once we release the new model. But I had a request from Senator Benson who asked to see it, so we just added it to the slide deck to make it accessible, widely accessible. To your question about what are we learning from it, and is there a recommendation built into it, I think I want to add 2 quick points. I think what we're learning from it is what we have consistently learned from this type of work. Extended stay-at-home orders or reduction in contacts pushes the curve out generally without necessarily affecting the peak of it, and I think that's what this slide is showing as well. The second reminder would be to say the model in and of itself does not produce recommendations. what it produces is a range of scenarios based on a set of assumptions that many times are hypothetical to provide state leaders a sense of alternative outcomes related to a range of assumptions. So there's not a recommendation built into that at all.
And as a brief follow-up then, whether it's due to the next round of modeling or just other things, the governor is going to be making a decision in the next couple of days on what to do with our stay-at-home order. Commissioner Malcolm, are you advising him one way or the other? I'm just wondering what sort of information you're providing him on this next is the key decision.
Well, there are just a large number of considerations and data points that we're looking at in terms of guidance that's come out from the CDC, our own thinking on what we know about transmission risk in different settings, where we seem to be in the curve in Minnesota. Certainly we saw a pretty significant increase in the rate of cases day over day from the food processing outbreaks, to be sure, but also that inexorable rise in underlying number of cases. So we're trying to factor in not only whether the shape of the curve or the steepness of the curve is changing and accelerating and what that might portend for faster rates of growth in rates of hospitalization and ICU use going forward, as well. How are we feeling about the supply chain and our success in building up a state-level reserve of critical equipment, since we have known for some time that the Strategic National Stockpile was probably not going to be a resource for us at least in the next number of weeks. So just kind of assessing where we are on all of those variables that the governor set out as the things he needed to see: increased testing, increased healthcare supply, some confidence in the flow of information and how much real-time information we have about where we stand with hospital capacity and critical supplies, in particular against the rate of growth in the epidemic itself. So yes, there are active conversations going on. I think we're very much in the kind of the compiling all the data stage. So I certainly will be part of those conversations in the coming days. We're looking, and again, the version 3 results, we're eager to see them as soon as those are available. And that, I think, as the governor has said and Stefan has said, that is certainly one useful input among many. And certainly the economic data that Commissioner Grove speaks about on these calls quite frequently is another critical piece of information.
Thank you.
Your next question comes from the line of Kent Erdahl with CARE Television.
Hi, this question is for Stefan. Stefan, can you explain at all or help us understand why that latest release scenario might have shown different numbers? Perhaps I think there's a lot of conclusions being drawn by this, but I just want to understand why you believe some of this looks differently.
I'm not perfectly sure that I understand the question. Would you be so good to reframe it? And maybe while you try that, all I would say is that what the scenario shows is just sort of the relationship between longer reduction in the contacts and the timing of the curve. And the point there is typically that the way that happens is that as the virus doesn't get transmitted because of the reduction in contacts, the time to when the economy would be opened up and the virus again would begin transmission among the general population, that sort of dynamic delays the peak. And I'm sorry if I did not understand your question.
I guess, is there any indication, according to modeling, that delaying the peak too long or delaying anything too long as far as the stay-at-home order would have an opposite effect on overall cases or capacity or anything like that?
I see. Now I understand the question. Well, the way I would answer it is to say, perhaps you can give us a few days to answer that question, because we are modeling sort of a longer, we're modeling one of the CDC scenarios which had assumed a longer stay-at-home order, and I think some of the early IHME model scenarios had also assumed a longer stay-at-home order, and maybe I'm maybe the best way to answer your question is to let us look at the data once we have it. But no, I don't expect that a longer stay-at-home order would have unexpected results from everything that we've seen, including in other models. The longer the stay-at-home order, the flatter the curve. That may not be desirable from many other perspectives, but that is sort of the dynamic between the behavior of the virus, its transmission, and how it plays out sort of in populations.
Okay.
Your next question comes from the line of Esme Murphy with WCCO TV.
Yes, I had a question about the numbers reported over the past 6 days. In the past 2 days, you've had 480 or so deaths or new cases, and then 500 new cases today. In the previous 4 days from that, you had in excess of 700 cases. But when you look at the testing from the past 2 days, you've had close to 5,000 cases of testing. I'm wondering if this drop in cases as related to testing is significantly important to you as scientists, or is it a blip, or is it an indication that perhaps we might be going in the right direction?
Thanks, Esme. This is Commissioner Malcolm. I'm certainly going to ask Chris and Ruth as well if she would like to comment about that. And I would love to see that is the beginning of a trend in a more favorable direction. But I think wouldn't probably be indicated by just a couple of days worth of data. But I certainly noticed that as well. And that's certainly the combination we want to see is more testing and fewer positives being found, particularly of a community spread nature. But I think it's too early to declare it a new trend yet. But Chris, can you say more, please? And then Ruth, if you'd like to.
Sure. Esme, I think, as you know, we've had several situations in which there's been extensive testing done related to potential exposures in some processing plants and workplaces. And so we know that when the virus is introduced into those settings, it does really amplify, just as we see in long-term care. And so we were doing testing in populations in which we expected to see a very high proportion of positives. And so I think that accounted for the positives, the higher number of cases and positives that we were seeing last week. And some of that testing has leveled off, and that may account for the change. As the commissioner said, and as you're acknowledging, we want to see the percent positives reduced, but I'm not sure that we can say that at this point, because I do think that some of that focused testing accounts for those earlier positives.
Thank you.
Your next question comes from the line of Theo Keith with Fox 9.
Hi, Commissioner and others. I want to get back to this question over the modeling. I understand, as you've said several times now, that new modeling is going to come out this week. However, I want to ask about the comparison between Scenario 5 and the other scenarios in the version 2.0 modeling, because Scenario 5 was just added publicly, finally, last week. Scenario 5, the extension of the stay-home order, produces worse outcomes in that model than the scenario that we're currently following. So when you saw that, did that take an extension of the stay-home order until the end of May off the table?
Well, I'm certainly going to let Stefan answer that again, but I do think, as you said, the version of the scenario 5, as you described it, was kind of out of date almost as soon as it was posted, only because the model itself is being updated with new criteria. So whether it would continue to show that with the new run, we can't comment on that until we see that new run. But Stefan, perhaps you can explain it better than I just did.
Well, Commissioner, thank you. I think you actually did a really nice job to sort of say the purpose of Model 3 is to layer in updated data and make other structural changes in the model that helps us better reflect what we see on the ground and how the epidemic might evolve. So to some extent, I guess we didn't realize that model scenario 5 would generate such interest. Maybe an oversight on my part, but essentially, I think it might be best to set it aside. Now, since it's out there, I would just say, I would actually go to slide, for those who have looked at it, I would actually go to slide 19, and where the uncertainty estimates are as well noted to sort of realize that the uncertainty sort of overlaps with the existing scenario, or the scenario that approximates the circumstances in which we exist right now. I think the way this has been explained to me at some point, where a marginally longer stay-at-home order can certainly generate more time, but it can have a greater demand for top ICU, or also marginally increase mortality, that sort of relates to the fact that you're pushing immunity out farther, so that at the point at which the economy opens up and individuals circulate, the number susceptible to the virus is greater than under a different scenario. But I think that's really all I'd like to say, and really hope that you give us a few days to present you with what is a more refined and robust model that has also gone through some peer review. So we haven't mentioned this before, but for version number 3, what the research team has done has gone through some leading modelers across the country and asked them for input on the model. So that took about a week for the review and the assessment, and we want to take the time to build that in, so that we're doing the best jobs for Minnesotans that we can do. Ultimately, also, as we promised as well a few times, when we release the results from Model 3, we'll also release the programming code. So I want to make sure that that stands is at a level of robustness that suits the importance of this exercise.
Okay, one very specific follow-up then. Given that the results of Scenario 5, extending the stay-home order through the end of May, did not show very good results in version 2, has it been rerun as part of version 3?
Yes. So maybe one clarification. We're not focusing all that much time on Scenario 2 through Scenario 4, because that is the past. But we are looking to incorporate a range of scenarios, including Scenario 5, into our analysis for version 3. So that seems appropriate to us.
Okay, thank you.
Your next question comes from the line of Tim Nelson with Minnesota Public Radio.
Hi, I want to return to Assistant Commissioner Huff's comments a little bit this morning. It looks like you're up to 4,800 tests over the weekend on a daily average, closing in on that 5,000. The governor talked last week about sort of a drop in demand. At what point are you going to say, come on in, asymptomatic folks, and get a test, or at what level of testing will you say anyone who wants a test can get it?
Well, I think this is Commissioner Malcolm, I think we're going to continue to be really most focused on what are the best uses of testing technology and which type, whether it's the diagnostic testing, the polymerase chain reaction, PCR tests, or other kinds of tests, rapid tests or serologic tests. There's work going on right now and discussions amongst the clinical leaders around the state and the research teams at Mayo and the U about that. We do have a lot of concerns, and Chris or Ruth, if she's still on the line, might want to comment to this too. But there are times and ways in which testing would be not helpful. If just anybody that wants a test comes to get a test, it's frankly not going to tell you much. It depending on the quality of the test, the accuracy of the test. Even if it's a great test, you can test negative one day and positive the next. So a single point in time test is important for diagnostic purposes and for treating people who may have the disease and identifying, as Chris said earlier, very importantly, the tests help to identify someone has the disease and has been in contact with other people so that we can try to interrupt the chains of transmission. But I don't foresee a time in which we would say anyone, whether they have any symptoms or not, just come on and get tested with a PCR test, because it's not going to be that valuable. We have definitely suggested, though, that people, particularly in congregate settings, we should use a fairly low standard, if you will, or low threshold for what symptoms should call for a test. That we're encouraging a wider array of symptoms to be considered reason for testing as we learn more about ways in which the disease can manifest that weren't clear originally. I would say just again, though, that I am very optimistic about this partnership that we have in Minnesota, giving us as good a chance as anybody to really understand where testing can be the most helpful and start to deploy that. I'd like to use some of that testing capacity that we have now to get going faster on the surveillance testing, going out and looking in populations, not just relying on people to come and get tested, but for us to go out and try to get some of that surveillance data is something we're going to be working on right away. Chris or Ruth, would you like to comment?
Well, Commissioner, I'll just reiterate what you said. One of the things that people need to keep in mind is that a negative test is just a single point in time. So someone who tests negative today may, in fact, become infectious tomorrow. And so we want to be judicious in, how testing is used and the interpretation. So that's a consideration of just widely testing asymptomatic individuals. We also know that we have many facilities that we want to be doing testing in as it relates to the governor's 5-point plan for long-term care, and we are working on operationalizing that, and that too will use a large number of tests.
I just wanted to follow up real quick, Commissioner, since you did mention serological testing. Have you done any? Do you have any data? Are you going to release it anytime soon? What's the status on that right now?
Commissioner, I think you might have a mute button
I apologize. I did indeed. Thank you, Mike. I was asking if Dr. Lynfield was still on the line. She could comment on that. I know she's been actually designing some serology studies with colleagues at the U and Mayo. Ruth, are you still on by chance?
I am on. Thank you very much, Commissioner. Yes, we are planning some seroprevalence studies to get a sense of the number of people or the proportion of people that may have been exposed to this virus. And we are just going through the processes now and the contracts and hoping to get that up and running very shortly.
But no testing results so far, nothing ongoing that you can tell us about?
Well, I know that Mayo and the University of Minnesota and probably others have serological tests. My understanding is it has been used in some circumstances. But as I think we have discussed on prior calls, at this point in time, there are a lot of unknowns about immunity for this virus. And we don't know what is protective immunity. We don't know how long it may last. And for a specific individual at a time when the prevalence of the disease is low, the accuracy of a positive test goes down. So there can be false positives. So at this point, we have not recommended using it for individual decision making.
Thank you.
Thank you.
Your next question comes from the line of Bill Warner with Minnesota News.
Hi, Commissioner and others. Thank you for taking the call. Can you give us a rough outline of how things are looking at food processing plants in Minnesota, and are there additional hot spots that are creeping up that you have a particular eye on? Are we static? Are we gaining? Are we losing ground? Is kind of my question on food processing facilities in Minnesota and immediate vicinity also.
Sure. Thanks, Bill. And I think it's a mixed picture. It's stabilizing in some areas and still growing in others. But I'll turn to Chris for a more up-to-date answer.
Thank you. Yes, we are continuing to see cases identified that are associated with processing plants, with manufacturing, with those essential services in which employees necessarily need to work in closer quarters than someone who has the ability to be in a cubicle, an office, or work from home. So we're continuing to see cases in multiple facilities across the state. And in many of those cases, in many of those facilities, there has been testing, as we talked about, of all employees. But our first bit of guidance and recommendation for these facilities is that they do aggressive and very robust employee screening prior to entrance to the facility. So in addition to social distancing measures that they may have taken within the facility to reduce interactions between employees, we also are recommending that they are screening employees before they're allowed into the facility, and that they have a very, very low bar for identifying employees who need to be evaluated and tested. So we're encouraging robust screening and testing of any employee with any symptoms. And so that's our first approach. And then in some cases, it makes sense to go on and do more extensive testing within the facility. But we do have a number of different sites across the state, as I said, in which individuals who are working in these essential services and do not have the luxury of working from home or working in an office, a cubicle, we are seeing spread in those facilities and working with local public health and the facilities to address that.
Just a quick follow-up on that. Are you getting good compliance with your recommendations, and are there plants that you're anticipating could be on the verge of closure, at least temporary closures? We've seen some reopenings, but at the other end of that.
Certainly, there's a range of participation and accepting our guidance from different facilities. We do work with them and provide them with guidance, written guidance, as well as phone calls. We've done some site visits. So we're providing lots of guidance. Differing plants have differing approaches to adopting that guidance, and certainly if there are situations in which we feel that there's a concern for worker safety, the Department of Health partners with the Department of Labor and Industry as a regulatory agency that has jurisdiction over those things. So we're working at both angles, both from providing guidance as well as knowing that there are guidelines, or there is the opportunity for regulation and work done by the Department of Labor and Industry. And at this point, I'm not aware of any plants that are looking to close in the near term, but certainly as they identify more cases, that impacts their ability to continue their operations. And so they would be evaluating whether or not it makes sense to continue operations. But at this point, no, I don't have a particular plant that we think is imminently going to be closing.
Thank you very
much. Operator, we have time for one more question.
Yes, sir. And your next question comes from the line of Matt Sepik with Minnesota Public Radio.
Hi there. This question is for Dr. LYNFIELD. I am curious about how many doses of remdesivir we have received here in Minnesota. And I know the ethical guidelines are posted on the website. I just brought them up. But if you could give, in a nutshell, what those are, who is favored and most likely to get doses of remdesivir based on those guidelines.
Sure, I'm happy to talk about that a little bit. So on Saturday, we received a shipment of 1,200 vials. It's administered intravenously, and it is 11 vials used for a 10-day course because you use 2 vials on the first day. It is 6 vials used for a 5-day course. And so if one were to go with the 10-day course, that would be equivalent to 109 courses or thereabouts. And so our recommendations were to consider the highest priority patients, and those would be those that were laboratory confirmed by PCR to have SARS-CoV-2 virus, who are not already on remdesivir, because some patients actually are on remdesivir already because of clinical trials or compassionate use. Gilead, the company, has a compassionate use program for pediatrics and pregnant women. And the other components were people who were ventilated for 5 days or less, or were on extracorporeal membrane oxygenation, or on advanced respiratory support, such as high-flow nasal cannula, CPAP, or BiPAP. And then there were some criteria, according to the emergency use authorization, that had to do with having elevated liver function tests or poor kidney function, where they recommended that people not get the drug. The second priority patients were those who had severe disease, but not as severe as the highest priority patients. So if facilities have met the needs of the highest priority group, then they can allocate based on patients who had evidence of low oxygenation level on room air and had a requirement for supplemental oxygenation, lung infiltrates on imaging, an elevated respiratory rate, that sort of thing. And that is in the allocation guidance. So you could take a look there to see what the details are. I will say that we did do a census of patients in Minnesota facilities that were PCR positive for the SARS-CoV-2 virus, and based on that, we made our distribution, which the State Emergency Operations Center helped us with that. They had drivers who actually went out to the facilities. Tomorrow, we are expecting another 400 vials. So again, depending if it were a 10-day course, and it's the 10-day course that's recommended for that really severe group of people who are on a ventilator or who are on extracorporeal membrane oxygenation. Those patients who don't have as severe disease, clinicians can assess them at day 5 and determine whether they can stop the remdesivir or if it looks like they really do need to continue for the 10-day course. So as I said, tomorrow we are expecting 400 vials. So if it were a 10-day course, that would be enough for 36 patients.
Okay, I'm glad you did the math there because that was going to be my next question. In that case, are all of the patients who receive remdesivir, are they automatically enrolled in a research study for the drug since this is still at an experimental stage, as I understand it?
Right. No, they're not. There are still some trials that are ongoing right now that are looking at various things, maybe, and I'm not totally sure of all the details, but I think it's looking at 10 days versus 5 days and different levels of severity. However, as you may recall, Dr. Tony Fauci a few weeks ago looked at the preliminary data and felt that there was enough evidence at that point that an application should be made to the Food and Drug Administration for the emergency use authorization. And so based on the preliminary data, FDA did issue that EUA, the emergency use authorization, and in there it needs to be explained that we don't have all the data yet. These are the preliminary data, and so there does need to be conversation with the patient or with the patient's representative, but it's not considered a study.
Okay, and then just one final follow-up to that. After this 10-day course runs in these patients who are getting it now, will you be able to share those results in any way with us to show how well this is working and if it is indeed reducing the amount of time that they spend in hospitals?
Well, I would say the most robust data on that are the data that are coming out of the clinical trials because they are collecting a lot of information on each patient. And when you're looking at effectiveness, you need to take into account things like underlying conditions, what their oxygenation level was prior to the drug, how long were they symptomatic before they got started on the drug. So those would be the most robust data. We are collecting information on hospitalized patients that have SARS-CoV-2 laboratory-confirmed infection in the metro area. We're doing a deeper dive. We are doing a case abstraction on these individuals, and so we will have data coming out, not solely related to people on remdesivir, but in general, because we do have a lot of questions, and we are collaborating with the Centers for Disease Control and Prevention on that surveillance, as well as a number of other states. And you can see that some of those data go into the CDC weekly updates on COVIDNet. Some of those data are from the data that we collect.
Okay, thanks very much.
Yeah.
that's all the time we have for today. I want to thank our speakers and the reporters on the call today. If you had a question we were not able to get to during the call, please feel to reach out to our office at 651-201-4989. Have a good day, and we'll talk with you again soon.
Find more local news stories at ccxmedia.org and follow us on social media.